Hello, good evening everyone. Today we will be talking about spirometry. So before going into the details of spirometry, we will see about the physiological aspects of spirometry. So as we all know that normally the physiological aspects of spirometry includes various volumes, and the addition of those volumes are known as capacities. So first we have the tidal volume. So tidal volume is normal amount of air which we inspire or expire during normal respiration. So that amounts to be around 500 ml. Then there is inspiratory reserve volume. So inspiratory reserve volume is the extra amount of air which we are inspiring when we are forcefully inspiring after a normal expiration. Similarly, expiratory reserve volume is the amount of air expired forcefully after a normal inspiration. Then comes the residual volume. So residual volume is the amount of air which is left in the lungs after we undergo forceful expiration. So basically we have inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. Then there are various capacities. For example, there is inspiratory capacity. So inspiratory capacity is nothing but the combination of inspiratory reserve volume and tidal volume. Then we have the functional residual capacity. So functional residual capacity is the amount of air which is left in the lungs after a normal expiration. So it is a combination of expiratory reserve volume and residual volume. Then there is the vital capacity and the total lung capacity, right? So vital capacity includes inspiratory reserve volume, tidal volume, and expiratory reserve volume, while total lung capacity is the summation of all the volumes. That is, we can say that it is a combination of vital capacity plus residual volume. Now we have to understand that while doing spirometry, we cannot measure residual volume. So residual volume cannot be measured in the spirometry. Hence, if any capacity includes residual volume, then it cannot be measured in the spirometry. For example, functional residual capacity and total lung capacity, they cannot be measured in the spirometry. For us to measure correctly residual volume or FRC or total lung capacity, we have to make use of body plethysmography. So coming to indications of spirometry. So what are the various indications of spirometry? First is diagnostic. Okay, we diagnose obstructive airway disease, we diagnose restrictive lung disease. In fact, we differentiate obstructive airway disease into bronchial asthma and COPD, right? Then we use spirometry for follow-up of bronchiectasis, bronchial asthma, COPD, ILD, even neuromuscular disease, kyphoscoliosis, right? And for prognosis also, we use it in case of ILD, interstitial lung disease, neuromuscular disease, COPD, and bronchial asthma. Then we do the risk assessment before the surgery, especially cardiovascular surgery, and post surgery we also see the lung reserve of the patient. Also for lung transplantation we use spirometry. Then what are the contraindications for spirometry? So the contraindication for spirometry is, the most important contraindication for spirometry is recent myocardial infarction. By recent we mean that in previous 1 month or 4 weeks. Then recent thoracic or abdominal surgery, that is within previous 6 weeks. Recent eye or ear surgery, which is also within previous 6 weeks. So there should not be any closed space surgery, right? For example, if a patient has recently has an operation for cataract, so that lens may dislocate if we tell the patient to undergo spirometry, because what happens during spirometry, a lot of forceful expiration and inspiration is done. So because of that, the pressure in the closed space, for example intraocular pressure, that increases, and that leads to the dislocation of the lens. Then proven or suspected active pulmonary tuberculosis, right? So this is a contraindication because spirometry is a aerosol producing procedure. So what are the other aerosol producing procedures in pulmonary medicine? That is fiber optic bronchoscopy, and you have nebulization. So you have to be very careful when you are suspecting tuberculosis, or you are suspecting a community acquired pneumonia. So, you have to be very careful while doing spirometry, while doing fiber optic bronchoscopy, and while giving the patient nebulization. Such patients usually require isolation. So thoracic, abdominal, or cerebral aneurysm is also a contraindication. Other than that, oral or facial pain which is increased by the mouthpiece. Then another important contraindication is active hemoptysis, right? Then uncontrolled blood pressure and any acute illness that may interfere with the performance of the procedure, right? And then last trimester of the pregnancy is also a contraindication for spirometry, right? Then coming to the procedure of spirometry. So what happens over here is that we ask the patient to inhale deeply, then we close his nose by a clip, then we tell the patient to exhale forcefully into the mouthpiece. Then after a forceful expiration for at least 6 seconds, we tell the patient to again inhale through the mouthpiece. Then these graphs are made. So one is the flow volume graph, which is on the left hand side, and one is the volume time graph, right? So in flow volume graph, here is the residual volume, and over here is the total lung capacity. As we all know that spirometry cannot measure residual volume, so the point at which the spirometry starts is designated as residual volume. And what is the capacity in between them? That is TLC minus residual volume vital capacity, right? Then over here, the highest point over the flow is known as peak expiratory flow rate, right? And over here in between is the mid expiratory flow rate. So regarding volume time curve also, here it is given in seconds. So 1 second, 2 second, 3 second, 4 second. So over here at the junction of 1 second is the, here is FEV1, right? So similarly FEV2, FEV3, these are over the time period, and this should be at least for 6 seconds. So now coming to acceptability, when will we accept that the graph is okay, so that we can go on with our calculations, right? So the graph is only acceptable when your flow volume loop is complete, right? So flow volume loop should be complete, that is, and without any artifacts. We will be dealing about artifacts later on, so there should be no cuffing, no hesitancy, these should not be there. So and flow volume loop should be complete. Second, coming to volume time graph, that should be your forced expiratory time should be more than equal to 6 seconds, right? If it is not more than equal to 6 seconds, then what happens actually, then you are only calculating tidal volume and your inspiratory reserve volume. Your expiratory reserve volume is left out if your post expiratory time is less than 6 seconds. And as we all know that vital capacity is made up of all the 3 components. So even if one of them is missed, then your vital capacity is not completed, right? And third is, some authors believe that post expiratory flow rate should be more than equal to 2 liter per second, right? Other than that, other things are also there. For example, you should take minimum of 3 readings. That is, you should do spirometry for at least 3 times, and the largest of the in these 3 readings, the 2 largest graphs or the 2 best readings, in them FEV1 should not have a difference of more than 150 ml, and FPC should not be having a difference of more than 150 ml. For example, if one of the graph is having a FEV1 of for example 5 liter, that would be 5 liter, and the other one is having this thing of 4.5 liter, then the difference is 500 ml. Hence it cannot be accepted. So you have to take as many readings as there may occur, so that this condition is fulfilled, right? And maximum you can take up to 8 readings. Maximum you can take up to 8 readings. Minimum 3 readings. Maximum you can take up to 8 readings, or when the patient is fatigued, that is, he cannot do further spirometry, right? So that would be maximum readings 8 and minimum readings should be 3. Now what are the abnormal graphs that are encountered during spirometry, right? So these are the abnormalities which are encountered during the spirometry. For example, here the patient is coughing, right? So this is an artifact. Hence this graph should not be considered over here, right? And the second graph is that there is early closure of epiglottis, early closure of glottis, right? Early closure of glottis. Then in the third graph you can see that patient has become hesitant while doing spirometry. So the graph has started a little late. So this is known as hesitancy. Patient has become hesitant, right? And here you can see that patient has not put his maximum effort. This should be his maximum effort, and this is the graph which he is making. So this is known as submaximal effort by the patient, right? So these are some of the abnormalities which we get in the graph, right? This I have already explained. Peak expiratory flow I have explained, right? And one important thing, that expiration is above the x-axis, right? And inspiration is below the x-axis. This is one of the basics of spirometry, right? So inspiration is below and expiration is above, right? And this is a normal graph. This is a normal graph. It peaks and then it makes a triangular shape, and then inspiration is like a semicircle, right? So this graph is actually showing what is happening in this graph. Peak expiratory flow has decreased, mid expiratory flow rate has decreased, right? And there is scooping out lesion, or this is also known as a witch's hat. This is seen typically in obstructive airway disease, particularly COPD, right? And over here we can see that this graph which is made is the smaller version of the original graph, right? So this is known as graph within graph, or miniaturization of graph. This is typical for restrictive lung disease, right? So these are the graphs basically seen in pulmonary medicine. Now coming to the upper respiratory tract. So we already know कि above is expiration and below is inspiration, right? Then there are types of obstruction. First is variable obstruction, and other is fixed obstruction. Variable obstruction can be intrathoracic or extrathoracic, right? So you just have to remember that I is not with I and E is not with E. That is, in an intrathoracic obstruction there is problem in expiration, in an extrathoracic obstruction there is problem in inspiration, right? So for example, if I have to make here extrathoracic variable obstruction, so there will be a problem in inspiration, right? So you have to actually see that wherever there is a problem, that area will become square shaped, right? So there is a problem in inspiration in extrathoracic obstruction, so the inspiration wala curve, that inspiration curve will become square shaped, and the extrathoracic will be just like normal. I made slight error. Okay, so that will be like this, right? Now intrathoracic obstruction, problem will be in extrathoracic, problem will be in expiration, sorry. So the expiration wala the expiration curve will become rectangular or square shaped, and inspiration will be like normal, right? Then coming to fixed obstruction. So in fixed obstruction there will be problem in both inspiration plus expiration. So this curve will be like this. Now you have to understand that exactly this curve is not like this. In practical purposes it is like this, you know, and these are only suggestive of fixed obstruction. Okay, example of fixed obstruction is tracheal stenosis, right? Now coming to so you have seen the graph, you have accepted the graph. Now there is a result interpretation, that you want to know ki patient is having obstructive airway disease or restrictive lung disease, or he is having bronchial asthma or COPD. Then first of all, the first thing you have to see is FEV1 by FPC, the ratio of the forced volume expired in the first second to the total volume expired, right? So this is known as Tiffenau ratio, right? So if it is less than 0.7, then we assume that the patient is having obstructive airway disease, and when it is more than or equal to 0.7, then either the patient can be normal or he can be having restrictive lung disease, right? So you have to remember that in obstructive airway disease we make use of FEV1 in calculations, right? While in case of restrictive lung disease we make use of FPC, forced vital capacity. So coming to normal restrictive lung disease, then we take the FPC, है ना? If FPC is less than lower limit of normal, so in our general calculations we use lower limit of normal as 0.8. So if it is less than 0.8, then it is restrictive lung disease, and if it is more than or equal to 0.8, then we assume that the patient is normal, right? Now coming to obstructive airway disease, here I have already told you we make use of FEV1. So for grading also we make use of FEV1. So this is the grading: mild, moderate, severe and very severe. So this grading is universal. It is done in COPD also, it is done in bronchial asthma also. In COPD, mild, moderate, severe and very severe becomes gold 1 severity, gold 2, gold 3 and gold 4. You must not confuse severity of COPD with grouping of COPD, right? So grouping of COPD is done to actually assess ki what treatment we have to give to the patient, right? Group A, Group B, Group C and Group D, right? While here Group 1, Group 2, this gold 1, gold 2, gold 3 and gold 4, they are actually severity of the disease. If FEV1 is more than 80% of the predicted, then it is mild. If 79 to 50%, moderate. 49 to 30%, it is severe, and if it is less than 30%, then it is very severe obstruction, right? Now we have already discussed that your bronchodilator reversibility can actually differentiate between bronchial asthma and COPD. So what is this bronchodilator reversibility? So what we do after we have done this spirometry once with the patient, then we nebulize the patient with, either we give meter dose inhaler or dry powder inhaler to the patient, salbutamol 400 microgram or levosalbutamol 200 microgram, and we again do spirometry after 15 to 20 minutes. So for example, if you don't have salbutamol or L-salbutamol, levosalbutamol, then we can also go for ipratropium, right? Ipratropium around 160 microgram can be given, and we can again do spirometry after 30 minutes, right? In some condition, you may have to skip this bronchodilator reversibility altogether. For example, if the patient is having some allergic reaction to salbutamol, or if the patient is having any cardiogenic arrhythmia, then you might want to skip this, and you might want to you may assess the patient clinically and then provisionally diagnose him as COPD or bronchial asthma by his history and clinical features, right? So coming to bronchodilator reversibility, so here we see FEV1, because I've already told you in obstructive airway disease we usually see FEV1, right? So FEV1 should be increased by 12% and 200 ml. You should always remember that it is and, both this condition should be satisfied, right? So if bronchodilator reversibility is present, that is 12% increase in FEV1 is there and 200 ml increase is also there, then we label the patient as bronchial asthma. And if it is not there, then COPD, right? In children, we usually assume only FEV1 as 12%, and 200 ml is not taken over there. So in case of children, we only take increase in FEV1 by 12%, right? Now coming to some numericals. So these are some spirometry graphs which were made in my department. So coming to this, so first the question is, you have to accept the graph. So will you accept this graph? So first coming to the flow volume graph. So PFR over here is more than 2 liter per second, right? Then the loop is complete, right? Although it is small, but it is complete, and there are no artifacts seen over here. So flow volume loop is accepted, है ना? Then coming to the volume time graph. So volume time graph, you can see post expiration time is less than 3 seconds. Okay, it should be almost more than or equal to 6 seconds, but it is only 3 seconds. So this graph is not accepted. So we won't go to the next step. We won't see FEV1 by FPC. We won't be doing any result, and we have to repeat this spirometry test for the patient. So this graph is rejected, right? Now what about this graph? Here also loop is complete, so there is no coughing, no epiglottic closure, and peak restricted flow rate is also more than 2 liter per second, right? Then coming to flow time graph, volume time. In here you can see post expiratory time is around 3.5 seconds. So will you accept this graph? No, we won't accept this graph, right? Let's assume that this has gone over the 6 seconds and we have accepted this graph, right? Then these are the results of this graph. Okay, let's assume that the graph is okay and we have accepted it, and you have this chart which has come. This is a result chart that has come. Now you have to see whether the patient is having obstructive airway disease, restrictive lung disease. So first is, what do we see? We see FEV1 by FVC. That is the first thing which we have to see. So here FEV1 by FVC, this is the predicted value, right? But we don't have to see this. We have to see the pre value. Pre is pre bronchodilator, right? So pre bronchodilator value is 69.94%, right? So this is less than 0.7. So automatically we assume that the patient is having obstructive airway disease. Now what is the next step? Next step is, you can calculate severity of this thing, right? Severity of the obstruction. Or next thing is, you have to differentiate obstructive airway disease between COPD and bronchial asthma, right? So next thing is, you do bronchodilator reversibility. So after bronchodilator reversibility, this thing comes. Okay, this is not pre, this is now post, right? Post bronchodilator. So here the FE, now we have to see FEV1 over here, right? And this was the previous FEV1, 2.13, right? So the difference between 2.13 and 2.28 is around 150, so it is less than 200 ml, right? So this means that there is no bronchodilator reversibility. As remember that both the conditions should be satisfied. It should be more than 12% change and it should be more than 200 ml, right? So this is no bronchodilator reversibility, hence patient is case of COPD over here. So I think this is clear, and thank you.